All right. Well, good afternoon, everybody. We are going to go ahead and get started here today. We've got the recording going, and we are going to talk about MFEI. What is MFEI? Our general plans for MFEI at this point in time. A little bit of information about how the MFEI is actually scored, how we're going to be interpreting these questions that you may have seen. And then we'll have time at the end where we can just ask some general questions. You guys can give us any questions that you guys have, and we'll get back to you with any answers on those, or answer them now if we have answers for them. I will say that MFEI is, as any big project, still a little bit in flux. We know that MFEI is coming. We know that July 1st, we're absolutely starting on MFEI, and the basis is being set aside and not being completed anymore. So that 100% is going to happen. We do know that 100% of the time, we will not be asking for documentation. If you guys have had save the dates that you've had come through, the old save the date form that says documentation is required, I promise you, as of July 1st, we're not going to be asking for those. You don't need to send that in. No, and that includes PCSP, behavior support plans, behavior tracking data. We don't want any of that. When we, July 1st comes, when we switch over to MFEI, we're not going to be completing any of those. Feel free to continue taking data if you choose to as an agency, but that is not something that we will be seeking for purposes of the MFEI. So I just want to make sure that everybody's very clear on those things before we jump in and get started. Please hold your questions till the end so that we don't bounce around too much, but we will get to everybody's questions as well. So we will go ahead and get started. Oops. And I will be sharing my screen. All right, so again, we're going to talk about the MFEI today. So the very first thing is, what is MFEI? What does that mean? What does it stand for? Why are we here? MFEI stands for the Medicaid Functional Eligibility Instrument. This is a standardized assessment that's replacing the basis. It is based off of a tool called the Inter-RAI. So you could hear the MFEI being referred to as the Inter-RAI. The Inter-RAI is a standardized assessment. That is the actual assessment piece that's scored. That is the Inter-RAI with some additional questions pulled in on it that makes it kind of its new beast called MFEI. So MFEI is the functional assessment that's completed by the CDDO, and that determines eligibility for the waiver that puts the person on the waiting list or determines them eligible for the funding if they're going for a crisis request. And the MFEI is completed in the state KEMIS system for scoring. So there's an algorithm that the state has there that will score that determines whether or not the individual is eligible. There are two parts to the MFEI that the CDDO will complete: the information section and then the assessment itself, or the Inter-RAI section. So the information section is similar to what we've had under the basis, and it contains questions about the person's demographics, their diagnoses, guardian information, case manager information. It's not part of the score when it comes to whether or not the person is eligible for the waiver or not. It's only for informational purposes. I do want to give you some prep though, because a lot of these questions have changed from the basis, and they might require a little bit of background asking around in order to be able to answer these questions at the meeting. So these prep questions are listed here that we think might need a little bit of digging before you guys will be able to answer these at the meetings that we have coming up. So the first question is, does the family or the individual have an income that is below poverty level? And when I have this on the website for you guys, they'll have a link there that you can click to go to the federal poverty levels. But what we want to know is if the individual is a child, i.e. if they are below age 18, does the family, however many people are in the family, meet the federal poverty guidelines, yes or no? And then if it's an individual who is an adult, it's just themselves. Do they meet the federal poverty guidelines? Yes or no? So that is information we will need as part of the information section. The second one is an opinion that we have to ask the individual, and then we also have to ask the guardian if they have a legal guardian, and if they don't have a legal guardian, it would be the primary caregiver that is not agency staff. So it would be unpaid caregiver that they have. Natural community support. If they don't have a natural community support or somebody else that's there, then we will not be asking that question to anybody else, just so you know. But the question is, does the person believe that they would be better off living somewhere else? And if they say yes, then we ask a different community location, or maybe they believe they should be living in a more institutional setting. We're not asking like agency. Do you want to swap agencies? That's not the question. The question is compared to where you're living now, do you think you'd be better off somewhere else? And so it's a bizarre question that we've never really asked before at the time of assessment, but that is a question that is on the Enter RAI. And I just want people to be aware of that question and ready to answer it. The third one is, does the individual live with an aging caregiver? And they define an aging caregiver as somebody who is age 60 plus. So if their primary caregiver is age 60 plus, we will need to know that information. Simply a yes or no question. This does not apply to people that maybe live in a group home and have older staff that are taking care of them. This is simply like a person who lives with mom and dad, or a person who has a caregiver that they're living with that is aging. The next question is typically only for initial assessments, and because we don't know what the state system is going to look like yet, we are not able to get into that system yet. This is a question we're not sure if it's going to be on everybody's assessment for the first year. But like I said, typically this is only an initial assessment question, but I just want everybody to be prepped to answer it in case it is there for everybody the first time around. And that is two questions specifically. They want to know the residential history over the past 5 years. I don't want to know their addresses. What we're looking for is institutional care versus community-based care. So if a person has been in a nursing home for 3 months, or they were in the hospital for 2 months following an accident, or they've been in a state institution of some kind, is adding up all those periods of time in the last 5 years, and then how long were they in those institutions versus how long were they living at home or living in a group home somewhere in the community. That's what that question is about. Similarly, there's also a second part that says how many years of the person's life in total have they lived in an institutional setting. So if the person is, 50 years old and has been in and out of maybe psychiatric hospitals, nursing facilities, or other places like that, we have to add that total time and say they've spent X number of years in an institution versus X number of years in the community. Again, like I said, this is typically an initial assessment question only, but because we don't know how this is going to roll out, I want staff to be able to be prepared to answer these questions at the beginning, and we'll see where those go. And the last question is, at what age the individual left the family home? So at what age did the family move? Did they move out of their family home? There are some, I know, situations that it's not that easy. Maybe they moved out when they were very young. Maybe they were removed and placed in state custody. We have ways that we can score those things. But for individuals that did, move out of the family home into services or off on their own in the community, what we're looking for is just an age. At what age did that occur? Again, typically only an initial question on the initial assessment, but I just want to make sure everybody's prepared to answer that question as well. And then one more section here that make sure everybody's ready. This is every year we'll ask this question, and this is if there was a disaster, a big disaster, community-wide disaster, state of emergency, something bad was to happen, would individuals be at high risk because of these particular areas? So let's say the first question has to do with electric. So if the power was out throughout our whole community, would we have, people that needed to get out there, first responders that need to get out there to them because they don't have power. For example, maybe they have some kind of life-saving technology that's dependent upon electricity. Um, Essential medication that requires refrigeration. So like insulin or something that's going to go bad if it's not refrigerated. It's life-threatening if it's not there. So that would be electric emergency disaster risk. The second area has to do with physical impairments and whether or not the individual would be at a high risk in the event of a situation requiring evacuation. And they're at risk specifically because they have physical impairments that prevent them from being able to quickly and easily get out of the area on their own. The third has to do with medication assistance, that the individual would be at very high risk because they can't access essential medication. So without the medication, they would pass away. For example, insulin, again, would be another example of that. They must have the insulin or they could become very ill or even pass away. The fourth section has to do with cognitive impairment or mental health concerns. Would the person be maybe unable to recognize that there was an emergency happening or make a reasonable decision to get out of the area to seek safety, to follow direction because of their cognitive impairment or their mental health concerns? And then the last area is that maybe the individual doesn't have informal supports. I mean, there's no family around, and they would need formal supports to help them get out of the area. So because they don't have those informal connections to the community, it does put them at risk in the chance of an emergency. All the manual says about this is that the state is using this information to, quote, flag a person in the event of a disaster, and that the state will use that information to quickly identify people who need first response and get the help out to them. So that is the information section, and those are the questions that I definitely wanted to make sure that you guys were aware of. We will go through the assessment here in just a few moments, and we can look at some of the other questions to see what they look like, but those are the ones that I believe would be most concerning to individuals and needing information to be able to answer. The second part of the MFEI has to do with the actual assessment, and it's broken down into 3 areas, just exactly like the basis was. So the first section has to do with the person's health. There's questions regarding medical diagnoses, the medications that they take, and then the supports that are needed for medical concerns. Those questions do look slightly different than what you're used to on the basis. And the other thing that I would mention at this point is that in the information section, we do track the individual's diagnoses. That is the one thing that absolutely will require documentation if there is an update or a change, because a diagnosis is something that is given by a medical doctor, by a psychologist or something. We do have to have that in writing, as it could change their eligibility. It could have eligibility ramifications because of it. So that is the one piece of documentation that we must have when it comes to this assessment, is if there's a change to the person's mental health or their IDD related diagnoses. We do not need that for medical diagnoses though. Okay, so medical diagnoses, we don't need the documentation. But anything for eligibility purposes, either mental health or IDD related, we do have to have documentation still for that, as we have this whole time. Oh, let's go back one more time. Okay, the second part of the MFEI is the adaptive section, and this is regarding questions about the person's communication, cognitive, and motor skills, very similar to the basis, but the scoring is going to look very different. We will get into the scoring here in just a moment. Same with maladaptive. It is the last part of the assessment, similar to what you've seen on the basis in some ways, but vastly different in others, and we will dive deeper into that section as well. One question here in the assessment that I did want to pull out that will likely need prep work is on the adult assessment. We need to know how many falls, so how many times they fell down in the last 30 days, and then 31 to 90 days, and then 91 to 180 days. This is not, there's no guidelines around that as far as the person had to seek medical care or anything like that. We just want to know the more a person falls, the more at risk they are. And so these questions are there to kind of draw that information out. It's the best that you guys have as far as information when it comes to that, but just be aware that is annually we'll be asking the last 30 days, the last 31 to 90, and the last 91 to 180 days for that question. The other thing I want to make sure I pull out before we get too much further into coding and how these things are coded is look back period. In the basis, we've had the same look back period for every question in the last year, the average over the last year, or, you know, roughly over the last year, what was a normal day look like or whatever. The look back periods in MFEI are very well defined, and it's different for a lot of the questions. So this might be a section if you're not sure what the look back period is or what time period we should be looking at to answer, ask the assessor. They've been told and trained to give this information up front so that hopefully you guys will have that right at the front so you know what you should be thinking about. For example, some days have a 3-day look back. The behavior section, for example, is a 3-day look back. Some questions are as of today, this day alone, how are things today? Some have a 7-day look back, and then just like we talked about with falls, others have these time periods that we're looking at. So it is specified on almost every question exactly what the look back period is. And if you are unsure, you can always ask what that looks like, okay, for that look back period. So assessment coding for ADLs and IADLs, or, you know, activities of daily living, are, we are used to things like, you know, prompting, or it's, you know, total support or independence or whatever. We have some different types of skills now that we're looking at, from independent, modified independence, minimally impaired, moderately impaired, or severely impaired, with the very last one, the most severe, meaning no discernible consciousness, or the individual's in a coma. I think that that's one that we will use very infrequently, but that is the new scale that we're looking at it. We only had 4 options on the basis to scale people on how they did with their ADLs. On the MFEI, we have 6 now that we can utilize. And then, so talking about coding, not only now are we coding how well they do, we also code for capacity. So performance is, how do they do the task today? How today did they do that? So let's say, for example, the individual lives at home with mom and dad. Mom does all the grocery shopping for the whole household and does not typically take the individual with them. Not because they can't go, but just because it's easier for mom to go do it on her own. She gets it done faster. And so that's performance. So today it would be coded, if we go back to our scoring here, as maybe very dependent because mom does it all. But the capacity calls for speculation. So capacity is the presumed ability. So maybe the individual is very independent and could absolutely go to the grocery store and take care of some of these things. Then we would be scoring them based upon what we think their capacity is, getting to know them. So this assessment does absolutely call for speculation by the assessor and by the team when we're answering some of these questions. For youth, we don't look at capacity because they're growing still. We don't know their full capacity yet. But what we do look for is not only performance, the same as adults, how are they today, but then we want to know the effect. And this is a yes or no question, again, calling for speculation. So we would ask the question, does their disability have any effect on their ability to do the task? For example, that same situation, let's say that there's a 16-year-old, you know, that doesn't do the grocery shopping because mom does the grocery shopping most of the time, but they're very capable, and we believe that they could likely, you know, if somebody showed them once or twice, be able to go take a short trip through the grocery store. We would say that no, we don't believe the disability does affect that performance, even though we just in the question previous to this may have marked them as the most dependent they could be because mom does everything for them. And so that's how this assessment is looking at it. We want to know performance, and even though performance may be one thing, their capacity or their effect may be completely different. So I just want to pause here for a second and take a look at, if I can get my stuff working, at the actual MFEI that we have here in front of us now. This is the MFEI form, and I'm going to scroll down, hopefully not too quick. I don't want to make people motion sick today, and see if we can't get to some of the, here we go. So this is the health section we just talked about. Again, it has all of the same types of areas that we had on the basis. This would look very familiar for you guys. It is different now. I didn't mention this in the presentation, but the health section, we have not present, present and receiving active treatment, and then present but not receiving active treatment. This is different than what we saw on the basis. On the basis, if they did not have active treatment, we could not count that condition. It's no longer the case now on the MFEI. We can count those and we just put, they're not currently taking meds or getting monitored, but they have had this condition in the past. The seizure section is exactly the same as on the basis, and the same options are giving. The mode of nutritional intake has given us much more as far as options that we can put here and how the person gets their food. The other thing that I would say about the health section, we have thrown out a lot of times people's dietary requirements and food allergies because they don't meet the high standard that basis had. MFEI is different. So we can count things, any diet the person may be on, any diet they may be on, even though it's not doctor prescribed, it's not ordered. If they are, you know, following a kosher diet, we can list that here, kosher, but it's just not required by a doctor. And then yes or no if that requires staff support. So any dietary requirement that they have now, we can capture on the MFEI. Same with food allergies. So we do have a lot of families that tell us that the individual is allergic to something, but it has not been verified by a medical professional. So in the past, we have not been able to count that. Now we can. We just have to mark yes or no whether it's been verified, and then we can mark whether or not it requires staff support. So I do like that it allows us to drill into those questions a little more and capture more of that information that in the past basis has skipped right over. The medication section is pretty much the same as it has been. The route of administration, it looks different because we have to ask for every type of medication they take, how what their level of support is for that particular type of medication. So if, for example, oral, they're taking an oral medication, you know, how much help do they need to take that medication? All the way down to, you know, eye drop, of course, is different, or inhalation, you know, if they're on, you know, a breathing machine or something, you know, to take albuterol, what that looks like. We still have the same rule around injections, which is what this note is here, that injections for things like a flu shot does not count towards a medication, but ongoing injections like the depot shot absolutely does still count. So same. The other question that I think is quite interesting that I am glad to see on the MFEI is whether or not additional assistance is needed at healthcare appointments, and this includes the dentist. And this is whether or not staff support is needed, how much staff support, and then if medication is required as well for the individual, like a sedative or an anti-anxiety medication. So again, we're able on the MFEI to pull in more information that we have not been able to previously. Okay, this is the adaptive section here that we're into now. A lot of these questions are similar to what was on the basis, or maybe we captured these things on the basis, but we asked the question differently. And so you'll notice that some of these, like hearing, vision, these are exactly, almost exactly what they were on the basis as well. Reading, writing, give us a few more options, but still very similar to what we had on the basis assessment. Their motor skills, we might have asked, you know, can the person go up and down the stairs alternating feet? Well, now we just say, how are their gross motor skills? And we list those things here. So you see, we're capturing the same types of things, but the questions are different. Fine motor skills, we might have said, you know, can the person make a mark on a piece of paper? Can they draw a circle? So we're talking about fine motor. Now we just ask, you know, how are their fine motor, rather than the broken out questions like we used to. Here's that question I was talking about falls that's here in the assessment section. Susceptibility to victimization. This is new on the MFEI. And it has to do with if the person's cognitive abilities or their physical abilities, what might make them more susceptible to victimization and their judgment in emergency situations we've talked about there. Okay, this is the part that I was talking about that we wanted to go over that has to do with performance and capacity. This is the adult MFEI, so it's performance and capacity. Remember, for youth, it's very similar. It's just performance and effect. So, for example, here, how are meals prepared? This could be that mom does all the cooking, like I stated before. So total dependence, 6. Mom does everything. He's not doing anything. Would be what we mark the performance. But the capacity could be independent, even though we just marked 6 as total support for performance. So these things are okay not to match. What we want to know is what was the performance, and then what do we think the capacity is? Okay, and I'm going to keep scrolling here to get to this one. This is, again, different because we don't necessarily look at capacity on this. These are ADLs like bathing, hair washing, brushing teeth, those kinds of things. So the first thing you notice is that we're only scoring for performance. We only want to know, did they need help? What was going on? What did they receive over the last 3 days? You see, this is a 3-day look back period. And we also can score the activity did not occur. So we do have people that maybe didn't take a bath in the last 3 days, and we would just score that did not occur, and that's okay. And you see, the other thing is that we've split dressing into upper body and lower body. I love that because some people can easily put on their pants, maybe pull up their pants, but getting the shirt the right way around and everything is different. It could be completely different. We will also be asking questions about menstrual cycle. This is about the most recent menstrual cycle, not 3-day look back. So they don't have to be currently on their period or just finished their menstrual cycle in order to answer these questions. Down here at the bottom is where we're looking at, did they need additional help? So we had performance, right? So we know what they did, but maybe they need help. Okay, so if you think about it like this, the individual had they say that they're bathing, they're independent and they're bathing, but we're looking at them and saying they emit an odor, they don't look clean. That might be an area that they need additional support in based upon what I'm seeing, or based upon a report that they're not taking care of themselves well. We can mark those down here that additional assistance was needed in that area above and beyond what they actually had in the last 3 days. So you see, you're not penalized because in the last 3 days they didn't do these things, or the last 3 days they just happened to be independent in those things, because we are still capturing that they needed more help than what they got right here in this area. So we're still able to get those things, which I appreciate again about the MFEI, that it's allowing us that ability. Okay, before we get to the maladaptive section, I want to jump back to our PowerPoint and let's walk back through, oops, where we are there. Skip back to our slide. Okay. The maladaptive section has been redesigned to capture not only that the behaviors that the person does now, but also the support level of staff that they're giving to prevent the stuff from happening. On the basis, you could see that somebody might have extreme behaviors, and then an agency or staff are doing a great job at bringing those behaviors under control, but it takes a lot of work. It takes a lot of staff. It takes a lot of everything, to make that happen. And then you see the tear fall because now they're not having these behaviors anymore because the staff are doing all this work. The new maladaptive section under the MFEI allows us to capture not only did the behavior occur or not, but what did you do to prevent that behavior from happening? So we're able to capture all that support that you guys are giving people to help prevent the behaviors to begin with. So it's broken into 3 areas of question. So number 1 is in the last 3 days, we're on a 3-day look back. Did they display the behavior? Did they do it? Yes or no? The second part is, okay, if they do that behavior, whether or not it happened in the 3 days doesn't matter. If they do that behavior at all, what do staff usually do? What do staff typically do to respond, to prevent, to address that behavior day to day. And then the last question, the last part of this is, how frequently do staff need to do that to prevent or address that behavior? And we'll look deeply into this section in just a moment. The other thing I want to pull out about the maladaptive section is that we do have a couple of additional questions now that we will be asking. The next part of this is that overnight behavioral support is not captured in the front end. We want to know about that separately here. So it's a separate question from waking behavioral support, and the look back is current status. So we want to know currently, do they require help overnight because of behaviors? For example, maybe the individual gets up and will steal items, or they're getting into food, or they require wake staff for some reason because of what they're doing overnight. We can now capture the fact that we do have to have a wake staff overnight because of behavioral supports for this person. And then the last piece of this is a new question about extreme behavioral disturbance. And when I say extreme, it means it very extreme. I included the definition and stuff on here and coding consideration, but we are looking at very serious risk of self-harm or harm to others. So I don't mean somebody who says that they're going to hurt themselves, but has never done anything. Like, we're talking an individual has actually attempted to harm themselves and would have also been successful if staff hadn't been there. The staff or the client has attempted to hurt severely, murder other staff, other clients around them. They've had severe cruelty to animals, fire setting, things like that that are extremely dangerous and above and beyond any kind of normal middle ground. So in this situation, we will look at the scoring, but we have to know not only what happened, but we got to have details. What would staff do? What did happen? It does not have a look back period necessarily. The look back is their entire life or extreme behavior disturbance. So if they committed manslaughter 20 years ago, we're going to capture that they committed manslaughter 20 years ago. That might not be a current thing, but it's definitely something about that person that you want to know because it did happen. And there's always potential that it could happen again. So that is a new question that we'll have to talk about. If there's something that you're not sure if it should be captured there or not, talk to your assessor. Feel free to reach out to me. We're going to work through this together as we're learning about this and what should go there and what shouldn't. But everything that we've been trained at this point is that this is extreme behavior disturbance. Okay. All right. Let's finish up the PowerPoint here, and then we will jump over to the maladaptive section and pick up the rest of the assessment. So the next parts of this, we want to talk about kind of the MFEI in general and about the funding of the system. I'm sure most of you have heard that they're no longer going to have tiers of funding as of July 1st. The MFEI assessment is not tied to provider reimbursement at all at this time. Its only use is to determine whether or not the individual meets the minimum score in order to be level of care eligible for the waiver. How much the providers are going to get paid for supporting that individual is not at all going to be tied to the MFEI as we know it at this point. Individuals that don't meet the level of care eligibility are not eligible for the HCBS waiver. But I would also put a side note there that just because a person is not eligible for the HCBS waiver doesn't mean that they don't get help. Those individuals are then added to the local state aid waiting list in which they can get state aid services and still get day residential employment support, whatever it is that they're needing through state aid. So just a little plug there. If you weren't aware, it's not HCBS or nothing. It is HCBS, and we also have state aid for those individuals who are not HCBS eligible. And I put a reference there to the CDDO policy that outlines state aid. And then the last note here is for this first year, individuals that are newly found not eligible, not waiver eligible under the MFEI, will be assessed utilizing the basis to ensure that they would also be not eligible utilizing the bases. My understanding is that this is for the first year, so that means July until the end of June next year, that will occur. My understanding is at this point that the CDDO here, we will be doing those basis assessments. That's what we're pitching to the state, that we would like to be able to do those basis assessments ourselves as well. And but we want to make sure that if a person is found not waiver eligible, that they truly are not waiver eligible, and it's not because of a fluke with the MFEI that made them not waiver eligible. So there is that. Who is assessed? This hasn't changed. We're assessing the same people that we always have, the individuals who are funded through HCBS IDD waiver services, those who have scored not level of care eligible on the previous assessment. So those previous people that we called tier zeros, those people that were found not eligible on that level of care, we're going to do the MFEI on them just like we do every year with the basis. Now we're doing MFEI. When children turn age 5, if they want to be placed on the waiting list, we will do the MFEI assessment on them. And individuals not on the waiting list for HCBS but want to be added. So if they fell off the waiting list for some reason and now they want to go back on, we'll do the MFEI at that point in time. So when we come to the actual assessment, we want to talk about what are people's roles, because those roles are changing slightly without all of the documentation requirements and everything that we've had in the past. So currently the case manager's role is to first notify the CDDO assessor if the individual or if the guardian would prefer an in-person meeting over a virtual meeting. Some people have a preference and really like in-person. Some people really like virtual. We can do either. And it's the individual or the guardian that chooses that method of having their meeting. Keep in mind, these are going to be very long meetings. We're anticipating, of course, and scheduling for 2 hours right now. I really hope we can get that much shorter, but at the beginning, I believe it's going to take a very lengthy meeting to make that happen. We're also continuing to ask the case manager to make sure that team members are aware of the assessment meeting, the date, time. We always include the day and residential provider that we have on record for the individual, but if there's other people that they would like to invite, absolutely invite them. Send anybody that the individual wants the meeting invite, the link to get on the virtual meeting, or invite them to the in-person meeting if they would like to come. We ask the case manager just to assist in reschedules if that is something that needs to happen. And also just to be at the assessment if you're there, to be able to give information about the individual and answer the questions as thoroughly as possible. It's something that the assessors are learning to cope with. Is like, you don't have all the data, you don't have all the information that you used to have. So we have to lean on the people who know them and not on what's written down in a PCSP as much. So just be there, be available to give information as possible. For the providers, right now, we just need you to ensure that staff that attend the assessment also can give information. So if they are going to come with somebody that maybe they don't know as well, can they have access to whatever information that may be available at the provider so that they can answer the questions as thoroughly as they possibly can, to ensure that the most recent medical and medication information is available to be shared at the meeting, specifically for residential providers, since you typically are the ones taking care of the individual's medical needs. Just make sure that those things are available to be shared at the time of the meeting. And for day program providers or maybe people that are doing PCS during the daytime, if the client's in services when the meeting is scheduled, please have the client there at the meeting. If the client is not available to be at the meeting, we have to reschedule those, and fitting those back in when it's a 2-hour meeting is going to be very, very difficult. So please have the person there. We want to minimize the number of reschedules if at all possible. And lastly, just so that everybody's aware, the individual, the guardian's role is to provide the most accurate and current information to the assessor. Of course, they're the experts on themselves or their loved one. And also that they can invite anyone they want to attend the meeting. We invite the team that we are aware of, the provider team, but they may have, you know, a caretaker, a next door neighbor, a family member, cousin, somebody who's very close to them that could offer some feedback. they're more than welcome to invite anyone they want to be at the meeting. It's their meeting. The next thing we want to talk about is the outcome. What are potential outcomes when it comes to this assessment? The individual guardian and the case manager are notified of the outcome of the MFEI through the notice of action form that's sent to them. It's got a lot of different names. We call that form a lot of different things. But I think you guys know what I'm talking about, the notice of action, the reevaluation notice, or sometimes people call it the MR4 or the MR5, and it could be MR5A, MR5B. That form is still the same as far as we know at this point in time, and that form will still be sent out. It will no longer, of course, state a tier. It will state whether or not the individual is eligible for the funding. And then the MR4, is what comes out if the individual remains HCBS waiver eligible. And then the MR5A, if they have an initial assessment and they are waiver eligible, and an MR5B if they are reassessed and determined not waiver eligible. Just in case you didn't know the difference between the forms, which I never can remember, but there it all is for you. When to make changes. Typically this falls on the case manager to make changes, but anytime a person has a new address or phone number, again, this needs to be updated and changed. Anytime there's a new case manager assigned to them, maybe a different case manager within the same agency, please let us know. If there's a change in their day or residential setting, we know that through options counseling, but we have to have the start dates and then if their address is changed. If there's any change in IDD or psychiatric diagnostics, again, listed here, that documentation is required to change those. And then to make changes to the information section, the consumer information changes form is found on our website. And when you have this, you can follow that link directly to our website and pull that form down if you don't already have it. The next thing that I want to talk about is MFEI accuracy and appeals. And this is to help minimize the number of appeals and to maximize our accuracy when we're completing the MFEI. The first part is if you're not sure how the assessor is scoring something, ask them. They will tell you. They could share their screen, they could whatever. If they don't know how they're going to score it yet and they need to research in the manual or something, ask them to let you know. They absolutely will get back in touch with you and let you know. If you're not hearing back from them, if you've asked for that, let me know. I absolutely will follow up on that. It is transparent. You can know exactly how things are scored at the time of the assessment, or if it's later, we can tell you how it was scored later. It is the responsibility of the individual, the guardian, and the team to ensure that all information is there at the time of the meeting, because once this MFEI is submitted to the state and the state system, we cannot make any changes to that. And so it is critical that the information is there at the time of the meeting. So please make sure that you are there with the individuals that can answer those questions. If you are in the meeting, for the last bullet here, and there's a topic that we know is very sensitive and we don't want to have that conversation perhaps when the individual is there, I could absolutely understand, that's a sensitive topic and we're not going to have a public conversation and we need to talk to you after for some reason. Let the assessor know. They will hold the assessment and not turn it in to have that conversation with you, and that you want to talk privately to them, but you need to let them know either before or at the meeting that you need to talk to them after the meeting so that they hold it, because they could, with the MFEI now, they're entering directly into the state system. So there's a possibility, depending on how their day is going, that when they are done with the meeting with you, if they don't know that you guys need to talk to them about something else, that they hit submit at the end of that meeting and the MFEI is done. It's scored and it's in the state system and we cannot make changes. So please, before the meeting or at the meeting, make sure that they know that you need to talk to them about something. Again, like I said, once the MFEI is entered into the CAMA system, we cannot make changes without KDAD's approval. Sometimes KDAD gives us approval and says, absolutely, go ahead. Other times KDAD says, well, they should have said that at the meeting. Too late, too bad. We can't update that. So just please make sure that that is available at the time of the meeting. Um, if it's not, and sometimes it's just not available, right? Let's be honest. Sometimes it's just not available. The guardian didn't come. None of us have control over the guardian was not able to be there at that time or place, or they had something come up and it's just not available. In order to make the argument to KDEDS about why the update needs to be made, we have to have some kind of justification as to why it wasn't available. So we're going to ask you, why wasn't this said at the time of the meeting? And you can say, oh, well, the guardian got pulled away and was not able to make it to the meeting and we didn't know. And so then we can pass that along to the state. I want to make sure that everybody understands this is the exact same as it was with the basis. Appeals have not changed with MFEI, exactly the same, but providers do not have appeal rights with MFEI. So please make sure that everything is accurate at the time of the assessment. The individual or the guardian is the only one with appeal rights, and the only time they can appeal is if it's found not eligible. If there's an error on the assessment, there's just an error on the assessment. They can't appeal to fix the error. And if the state says we can't update it, we just can't update it. But they do hold appeal rights if they are found not eligible for the waiver. And again, like I mentioned before, the first year we're going to be doing the MFEI. If they score not eligible, we're going to do the basis. And that is only for individuals who are found newly not eligible. So under the basis last year that we did, they scored eligible, but now all of a sudden they're not eligible. We don't want them to lose their funding until we do the basis again and make sure that that also would be not eligible under the basis. And the last point on here is that if you believe something's wrong with the scoring of the assessment, contact your assessor or just contact me. If you're having a problem with your assessor, if you don't, like the way it was scored, if you're not trusting the way that it was scored, if you have an argument about the way that it was scored, please let me know or reach out to your assessor, let them know as soon as possible so that if we can make an update, we can do that very quickly. Who should you contact? I listed on here who should be contacted in regards to what? Assessors, a general everyday stuff about assessments. Your assessors are going to take care of you. If there's anything else that comes above that, please let me know. I'm the service access manager. Concerns about the MFEI, questions about appeals, or if you need to request a MFEI to be done for, like, let's say you're working on a funding request of some kind, let me know and I'll help get that scheduled. Our basis liaison, who's going to definitely need an update to her title. That's Serena Brummett here, who's been with us for some time. She's still going to be doing the same things that she was doing in regards to the notice of action forms. If there's questions about KEMIS, if you need information on the basis, or I'm sorry, on the MFEI, Serena can typically get that to you. And if you need to make any information or service section updates, Serena takes care of that for you. And then I put a page in here of just our general email addresses. If you're assessors, we all follow the same naming convention, first name, period, last name @sedgwick.gov. So mine is heather.pace@sedgwick.gov. Serena.brummett. The basis inbox, we're continuing to have open right now, but it's going to be closing on 7/1. There will be a new email box announced, so watch that for information. Because we don't need all the documentation, we're going to configure how we utilize email accounts, and we'll be sending out new information to everybody on what emails go where and when and to who. So, all right, I'm going to shut that down for a second here. Let's go back to our adult level of care and finish running through this. This is our maladaptive section here, and you can see the different codes here at the top for section 1, section 2, and section 3 that we talked about. Now, the first thing I want to do is scroll down and look at the actual behaviors that we are looking at on the MFEI as compared to the basis. So under the basis, we only had one option for elopement. Now we can break this apart. So we have wandering, and then we also have elopement. So wandering is wandering without rational purpose, just kind of walking away. Elopement, that has some kind of purpose behind it, right? So they're taken off, they're trying to run away, they're trying to get at or get away from something. We continue to have things like verbal abuse, physical abuse. Sexually inappropriate behavior is now split apart into separate questions, which I truly appreciate. There's sexual abuse, and if you look down at G, this is inappropriate public sexual behavior or public disrobing. And so we can capture these things that we should not have been capturing under sexual inappropriate behaviors on the basis. Socially inappropriate or disruptive behavior is here. We had similar topics on the basis. Resisting care is the same as resisting supervision, basically, but it extends the definition a little bit to resisting ADL help or a hygiene assistance. Self-injurious behavior, property destruction is here. We call it now destructive behavior towards property because the property doesn't have to be completely destroyed in order to count it. Anger outbursts, pica is on here instead of eating non-food items, it's just pica. Polydipsia, this is excessive fluid consumption. So people who, kind of like pica, but towards water, towards liquids, they will do what they can to get it, and it can be very harmful to their health. Stealing, we're also adding in here bullying others and cruelty to animals. So those are the different categories we're looking at when we're talking about behavior. So the first thing that we'll ask is, did this occur? Did the behavior happen in the last 3 days? And it's not just yes or no, it's yes. I'm sorry, it's not present. So the person never does this thing. It's number one is present, but they didn't do it in the last 3 days, but they do have a history of doing this. The next one is that it was exhibited in maybe 1 or 2 of the last 3 days. And then the third one is they do this every single day. They did it every day the last 3 days. The next part of this is the support required. And this is what do staff do? What typically needs to happen if the person does this behavior? So 0. It could be that no support's needed. Staff can ignore it. They just, keep an eye. The second one is monitoring using, a person. I'm in the room and I'm actively monitoring what's going on. Or, through other environmental means, they're monitoring things. The second, number 2, there is verbal or gestural distraction or prompting. So I'm going to verbally intervene. Hey, Stephen, that's not appropriate. You need to have quiet hands. Or, hey, Stephen, I need you to come help me over here. I'm, distracting them to come over and try to help me in one way. The third would be hands-on support, one person. So I could be, physically redirecting them. I'm in there, I'm hands-on. I'm touching the person, doing something hands-on. And then number 4 is more than one person is needed to redirect. So 2 staff have to be there if this behavior happens, because it's going to take 2 of you to make any benefit here. Then the last section is the level of support typically needed to manage during waking hours. So it goes from no support required, which some of these are not present, and no support required, that's fine. So it could also be that, it's less than monthly that this happens, but but we're doing 2 to 1 if it does, so we're still able to capture that it does happen occasionally, that we have a lot of staff. It's just that it's less than once a month or so that it happens. And when you look at numbers 1 through 5, those kind of line up with basis when we would say, every day, a couple times a week, once a week. You can see that those numbers really line up with that. But when we get to 6, this is even above that. So continuous support during waking hours. They've got a one-on-one staff who's there and available for them. Number 7 would be line of sight. So they have a one-on-one staff, and they must always be in line of sight with the individual. And then number 8 would be within arm's length. So one-on-one staff, and they're always within arm's length of the individual that needs support. So those are the different support levels that we can now code. It opens it up from, a simple 5-level thing that we had to 9 different options for us now to be able to capture the support level. And so we will ask that for every one of these behaviors. Again, no documentation is needed for this. These are just questions we're going to ask the team and ask for an honest answer in return to that. Again, 28 here is that overnight behavioral support for the individuals who do require some kind of behavior support during the typical sleeping hours. We're not going to define those for you. It's just typical sleeping hours. The question about extreme behavior disturbance, you see, if yes, we have to describe the behavior and then we have to explain the supports or the response that would be needed. You notice that question 30 is directly off the basis. And does the behavior prevent the individual from moving to a less restrictive setting? For this to be yes, just remember that there has to be some kind of restriction in their current setting, because we're talking about moving to a less restrictive setting. So there's something about their current setting that's restrictive. So be ready to tell us about that. And the last one, this is, again, we're not requiring documentation for this. We're going to ask you if the person has a behavior support plan. And then we're going to ask, is the behavior support plan person-centered? Is it specific to the individual? Does it define the behaviors? Anyways, we go through all 4 of these, and then we can answer yes or no if it meets all 4 of these criteria, with the reminder that criteria for behavior support plans here is listed in KR 306323. So if anybody's curious, can definitely look up that reg if you want to know more about that. The last piece that's on here is our employment addendum. I did not include much about this into our PowerPoint earlier today. This is only done on individuals that currently are employed, or that we score as employed in the last year. During the earlier questions up in the information section, this will come up as a document that assessors need to complete. So we're coding this again, kind of similar to we do to ADL's performance. So we want to know the last 3 work days, what their performance was, but we also want to know capacity. And again, this is speculation is required by the assessor. So when we're scoring performance, if we look at the first thing here is understanding workplace logistics. So do they understand the wage structure? Do they know how to read their pay stub? Do they know how to file a grievance? Do they know if they have benefits, or if they get paid time off from their work or not? Or if they get an evaluation, do they understand that they could get, a raise if they're up for a raise, or what their legal rights are? So the performance we would code again with how much help they might need or to understand these things. So it could be that they're going to need some limited assistance. Maybe they need somebody just to help explain what these things are, what they should expect. And their capacity, again, maybe they're always going to need somebody to, because there's just so much, to remember. They're going to always kind of need somebody to help prompt them through what to remember. And we have this whole thing, again, 9 different options, all the way from 0, independent, the person gets it, they can adhere to their schedule, they know they're always there, they're great about being on time, whatever, all the way to this activity did not occur during the entire period. We can't use that for capacity, of course, because saying that something didn't occur for capacity doesn't make logical sense. We can say that performance wise, but because we can speculate, we can't use that for capacity. So it does go into a lot of different aspects of employment. So workplace logistics, scheduling, the social activities that come into being employed. Can we communicate with other people? Can we be respectful and have appropriate social interactions with people during work? Or if we're doing off the clock activities, like, are they appropriate in the break room when they're at work? Things like that. Quality of work. Do they complete their work assignments? Do they, maintain the materials as they're supposed to? Things like that. Work efficiency, that they have productivity that is comparable to that of coworkers. They're able to sequence their tasks, things like that. So we're going to talk about work efficiency with them. And then the bottom part of this has to do with, are they at risk of unemployment or disrupted education? So have they had an increase in absenteeism? That's a risk of unemployment. They could lose their job if they're not going to work. Do they have poor productivity or disruptiveness at work or school? Things like that. So you can see even poor hygiene down here. If they're going to work and they've got poor hygiene, that's going to be a problem. Or if there's something else that maybe is not one of these things that could put them at risk of unemployment. What is that? Because we have to describe it, but we can also count other things here that maybe aren't listed. So I do like that it gives us an open option here to capture additional things that might need to be known. Okay, I'm gonna jump back out of this form and see if we can't get back to our PowerPoint. Oh, and of course it's gonna take me to the beginning. Okay, let's go to the very end here. Do we have any questions? And at this point, Sherry Arbuckle, if you're still out there.
Yeah, I'm still here.
Okay.
Heather, there's two in the chat, and then I also put a note in the chat about the basis assessment if one needs to be done, that there's no documentation requirements for the basis either.
Correct.
One of the questions is, will clients be required to stay the entire time?
Absolutely not. In fact, we would ask that you guys manage that on your side. We will absolutely follow your guys' leads. You know the clients the best. You know what's going on, how their day has been, everything else. Just let the assessor know. Hey, Steve is here, but he's going to leave pretty soon. So can we do his parts first? And the assessor will absolutely do their parts first, and then they can head out. So if there's somebody who needs to get out, let us know. We can also take a break. So if we need to pause the meeting, take a 10-minute break, it is a long meeting, sitting on a Zoom. We've been on this Zoom for about 1 hour right now, and I'm sure that there are people who are probably exhausted and ready to jump off this meeting. So a long meeting is hard on everybody. We can absolutely take a break as well. We're following your leads when it comes to those things, but no, the client does not have to stay the entire time, and would not recommend doing it, especially if they're active people. They're not going to want to sit there.
Next question was, are guardians required to attend the meeting or stay for the entire time?
No, the only person that has to be at the meeting for any length of time is the client. We have to see the client, and then we need somebody who can answer questions. We prefer the guardians to be there if at all possible, but we need somebody who can answer the questions. So if the guardian needs to jump on and jump off because they're working, I get it, totally understand. I just need somebody who can answer the questions to stay and finish the assessment with the assessor.
Next question is, I'm confused. One of the slides stated the MFEI determines eligibility for services, but doesn't determine tier level. So how is the individual's tier level determined?
I feel like that Sherry Arbuckle would be a great one to answer that question.
So during this first year of the MFEI, the individual's current tier level will continue into the next year. For individuals that are currently in services. Individuals that are assessed for the first time after July 1st, meaning they have not been previously assessed with the basis assessment within the last 365 days, they will receive a specific rate that's been determined by KDADS. So the assessment itself is no longer tied to the reimbursement model. And during a transition period, KDADs, the MCOs, and the CDDOs and providers have been working to look at potential models going forward. And since that has not been decided upon, there's going to be one rate for anyone that enters the system after July 1st.
Mm-hmm. And I would note that that is one of the reasons that there have been so many assessments we've been trying to get in the month of June so that everybody can get a tier, that we can get a tier. Because once July 1st comes, there's no more tiers. If the person has one, they keep it for the next year. But everybody else new that gets their first assessment or is coming like off the waiting list and gets assessed with the MFEI, they'll just get that single rate. So, and then the method by which providers will be paid is still being figured out for the future, but for the first year, we know there's going to be a single rate and that the MFEI is not going to inform that rate. So the MFEI, if you think about it, is just like other waivers. If you've ever had clients who may be on the TA waiver or the brain injury waiver, It's eligible or not eligible. When they do the assessment, they say the person's eligible for the waiver or not eligible for the waiver. This is bringing the IDD system into line with the other waivers of eligible or not eligible. It does not affect the payment model at all, which is way different than we're used to. But that's the way it's going to be as of July 1st. Has nothing to do with reimbursement anymore. It's only eligibility.
The next question was, what will determine the funding rate as of July 1st? So I think we've answered that. If the two individuals that had those questions want to come off mute and ask additional questions, please do. And we'll pause for a minute to let you have, in case you have questions, follow-up questions. Okay. The next question is, so the MFEI has no effect on payment. Do you know how the payment will be determined? So I think we kind of went through that as well.
Right. Yeah.
Is there actually some detailed billing information for knowing how to set this up in our billing system so it gets billed out correctly?
I have not seen anything come out from the MCOs on that. I can follow up and ask Seth and then have Jeanette send that out, but I'm assuming you will get your direction from the MCOs. You know, if they're a person that has a basis assessment before June 30th, you're going to bill the tier rate that they receive. It would only be different for those that enter services had their first assessment done after 7/1.
Right. And at this point, I have no idea what that's supposed to look like. I mean, you're saying a rate. Does that mean the same like a 15-minute rate like they have today? But that, you know, it's good. Obviously, you're saying it's going to be different than a tier level rate, but it's still going to be based on a 15-minute rate. And do they still have auths by units?
My understanding, the units will not change. It'll just be what the rate is.
Okay. Thank
And
you.
I'll see what information I can get to get sent out to you guys. I have not seen, I want to say the residential rate was like 140, but I was out a few days and I wouldn't swear to that today. So we'll get some information, detail information.
Okay, that would be very helpful with July coming around the corner real
Yeah.
fast.
Yeah, well, I would assume the state would have distributed something by now that was a little more concrete, but
I haven't seen anything.
I'll follow up with Seth and see what we can get.
All right, thank you.
Sheila, is that you? I heard, did you have a follow-up question? The next question is there an education section for children use similar to the employment section?
There is not. The education section will be pulled in if it is needed based upon how the assessor answers the education questions at the beginning. So just like we have talked about the individuals, well, you know what? It'd be easier. Let me just show you. Let me show you because I have it pulled up here and ready to go if I can find it. The youth level of care is right here. So it's a little bit different, of course, for youth and adults. Some different questions are asked, but let me see if I can find that fairly easy. I am really sorry if I make people motion sick here. I hate scrolling with people watching. Okay, living arrangements, residential. Okay, their education status right here will determine whether or not or what part of that addendum gets pulled in to the assessment. So some of those questions will absolutely be pulled over. It's hard to tell because the MFEI, when it is done, it's not like there's a paper version, but it's not done on paper. It's done in the KEMA system, and then the computer has technology that pulls in the questions that are needed as they're needed. So we don't ask every question every time. We only pull in based upon certain answers, the questions that are needed. But we do have this question of educational status, and I want to say, I could be wrong. I am wrong. No, that's it. Is just this educational status right here. And so based upon that, it will pull in the questions out of that we need. So kind
Hey,
of
Heather,
yes,
do
kind
me
of
a
no.
quick favor.
Mhm.
Would you look to see if you can readmit June Snyder? I have tried to readmit her multiple
Oh,
times and can't get, it won't work.
I just tried to do that too. Whoop, somebody was just in. Somebody's joining.
Thank you.
Uh-huh. So, anyway, so I hope, does that answer the question about children and the educational status being pulled into those questions, that bottom section on the employment section that we were looking at?
You got a thumbs up, so I think so.
Okay, awesome. Thank you.
Next question. What if the person served is nonverbal or won't participate? Do you just need to get a visual on the person?
Exactly, just the same as always. I mean, nonverbal or won't participate, it still tells us something. So seeing the person still tells us something. It's still a requirement that we have to physically see the individual. And that's all we need to do. So if they want participate, you could even hold the computer to the room that they're in. As long as we can see the person, that's all we need to do. They exist, they're there. Okay, let's move on and do the assessment. Same as with the bases.
The next question was, how do we learn more about what billing changes need to be changed to accommodate this change in tier levels aren't going to be used anymore? Is the rate going to be used on the 15-minute units? So I think we've kind of talked about that. So we'll try to get KDADS to send something out. The next question is a new health exam needed each year, or is the health exam needed for the initial MFEI and then only when a new diagnosis is made? So not each year.
Exactly. We will not ask you for a medical exam for anything. Because a medical exam diagnosing a medical condition, so high cholesterol, I don't need that. I just need a staff to tell me that the person has high cholesterol. The only time I need proof of any diagnosis is if it is a new mental health diagnosis. So they were just, let's say, recently diagnosed with depression that we want to add to their list of diagnoses. They were just recently diagnosed with autism. We want to add that to their list of DD diagnoses. Those require documentation. Now, anything that has to do with health, seizure activity, I don't need any part of that documentation. We will not ask you for a medical exam. We should never ask you for a medical exam as of July 1st. No documents means absolutely nothing that you will need to send us as of July 1st, unless you're adding a psych or an IDD related diagnosis.
Okay, that is all of the questions in the chat. So if you want to open your mics and ask questions, if it starts to where people are talking over each other, we'll ask you to raise your hand. Otherwise, just open up your mic and ask your questions.
I have a quick question. Going back to the points you made on the medical or IDD eligibility, is there a sheet that we can have as a reference to ensure that during this transition we have submitted the proper documentation for these two different categories?
I I don't think that we have anything that says that, but we can definitely look at making sure that we get information out to you guys about what that exactly looks like.
Are you
So is
talking
it
about the
okay?
IDD eligibility?
Yeah, I think
Yeah,
she's
the
wanting.
IDD and the mental.
I thought, don't we have a fast fact on that,
I
Heather?
believe that we do have that maybe listed in fast facts, that I'll get you, but I can get you guys something that has that in writing so that you are not, so you know exactly what you'll be asked to prove and what you'll be asked to not send information in on.
That would be wonderful. Thank you.
Absolutely. But just to know that if it is a question that is in the health section, right, of the assessment that we would typically talk about. So do they have a cardiovascular? Do they have neoplastic? Do they have neurological disorders? If it's a part of those questions, there's no documentation at all needed. So just as an FYI, but I will work on getting something put up in writing if I can. There's my pen. Find my pen. All right. Anybody else have a question?
This is Tammy at New Hope. I do have a question
Sure.
for the question about have they missed 2 weeks or more?
Mm-hmm.
What changes in what you will need for that?
We just need you to tell us, have they missed 2 weeks or more? That's it. Verbal
Okay,
report.
you don't need to know.
Yes or no?
You don't need no dates or anything like that.
Nope. No, at the beginning, you know, if you remember when we were just learning about MFEI and the state still had all of these documentation requirements, that was one question that we were really concerned about because the manual stated from the state that you had to give us not only the dates that the person was out, why they were out, the specific, you know, diagnosis that they had, you know, they had the cold or they had the flu or whatever. Like there was a bunch of documentation that we were going to need for every single absence the person had in order to count that 2 weeks. All of that has gone by the wayside now. All of that's in the trash can. Now we just need you to answer the question. Zero information other than your response.
Okay, thank you.
Very welcome. Anybody else?
I might, I might add to that. If you're a provider that crosses over multiple CDDO areas, what Heather shared with you today about no documentation requirements should be consistently applied across 27 CDDOs. Why folks are thinking about additional questions, just I did put early on in Heather's presentation, we will make sure the PowerPoint gets on the website, a copy of the actual assessment. Many of you probably have already pulled it down from KDAD's website, but it does move around on KDAD's website. So just to make sure we've got one place where it hopefully won't get moved, we're going to put it on our website. And then there was one other item, the recording. We'll put that on the website as well.
Correct. And I'm
then,
also going to upload that into Relias for future as well. So new TCMs that come on down the road, they can watch the recording or access the PowerPoint as well in Relias. Anybody else with questions? Want to open the mic and ask? All right, not hearing any. I think my closing here would be that, you know, we're very, very excited. We've been hearing about this and working on this, you know, off and on since 2017. So it's going to be an exciting time for us. It's going to be a stressful time for everybody involved, I think, to try to see how this is going to go, what this is going to end up kind of looking like, how quickly we're able to get this done. I'm really hoping we can get the time down because I know that's going to be a barrier for a lot of people as well. My biggest ask to everybody is twofold. Number one, please stay flexible with us. I know that it's going to be a big change and it's going to be difficult, but we are going to do everything we can to flex to the benefit of the individual and of the providers to make sure that you guys are able to still do your business and do your work and that we're not keeping people longer than what we absolutely have to. The other thing that I would say is, I'm sorry, go ahead.
No, Heather, I was gonna suggest that maybe you talk about how we're implementing the first 3 months. We are not going to be doing 100%. And so I don't want people to get alarmed if they haven't heard that a meeting has been scheduled. So I'd like you to talk about that a little bit.
Absolutely. We are still in, because it's a big question mark right now. I still have two positions that we're looking to fill to take on 2 new assessors as well. So we will have a total of 5 assessors at some point in time. But the state has allowed us to kind of gradually bring MFEI into being. So we only have to do 50% of the assessments that we would typically do in July. So just know that if assessments are dangling and you're not seeing people get scheduled, it could be that, you know, they're coming in, but we're phasing in. And then as staff become better, quicker, we're going to be able to catch those up. We get more staff in, we're going to catch those up. It could mean that the assessor that you're very used to is maybe not going to be your assessor moving forward. We might have to juggle caseloads around or move things around as we gear up and go in. But what I would also really like from you guys is feedback as this is going. How I'm going to check in with you, and I just honestly, how's it going? What's it looking like out there? You know, and your guys' feedback, what you're hearing from guardians or persons served, and providers, your feedback. You know, it's going to be taking up staff time, so I definitely want to hear from you about the impacts that we're having and how we could potentially problem solve things, because I don't believe in any way, shape, or form we figured out all the problems, and that there's going to be new things that we didn't even think about that are going to pop up once we get started. But we're very open and interested also in what you have to say, and then in modifying processes as much as we possibly can to take all of those things into account. I know this is a huge change, so we're going to be very open and flexible and fluid, very fluid as we move forward with
Heather,
implementation.
MedLife had a question they put in. Does the assessment get done during the intake?
During the intake, no. The intake is done at the very beginning before we've even determined if a person is eligible for our service system. So remember that IDD eligibility is 2 steps. So the first is that there's eligibility for a system completely, right? And then if they are eligible for the system, then we look at the funding sources that they might be eligible for, and HCBS being one of those. So the intake happens when we're talking about the big system eligibility. MFEI will then, after they're determined eligible for the system, then the intake staff will be doing the initial assessment with them to determine whether or not they're eligible for the funding stream at that point. So is it during the intake? No, it's just after that time period when the person's determined eligible, but it's still done by the same person as part of the same workflow process, if that makes sense.
And then there was a comment. Thank you for providing us all with some direction and better understanding of the process.
We will absolutely do our best to keep you guys updated. I don't anticipate that we're going to pull all back together for a big meeting unless something major happens, but we will absolutely be giving email updates and posting things to the website as well. If I post something to the website, though, I promise I'll tell you it's there. I don't expect you just to go looking at our website constantly to see if there's something, but we will, you know, be posting it there. If you have guardians or individuals that are very interested in this that might like to watch the recording, it's available to everybody. It's going to be on the website, so they're more than welcome to come in and watch the video as well, and to ask questions. My email is open. Please shoot me emails, give me phone calls, whatever. If you have questions about this or feedback that you guys want to offer as we move forward, or ideas and thoughts, I'm very open to those as well.
One thing I would
Heather,
share
this
is
is
I think
Tammy again. This is Tammy again. Just to clarify in my mind, when we go back to the medications and the questions that'll be asked, so you don't want a copy of the medications anymore. You just, we can just have a copy and go down it and answer the questions.
Exactly.
Okay, thank you.
Correct. Yep, not a problem. Hopefully that's going to make everybody's life so much simpler. You don't have to pull this and pull that to send it in, and did they get it? And you have assessors are calling, I didn't get this and I can't score because of that. So it's all verbal report, every single thing.
Heather, can you hear
Yes,
me?
ma'am.
This is Sally Jensen with Catch.
Yeah, sure.
I think you guys already talked about this, but I didn't quite catch everything. So if you have someone that doesn't qualify, they did qualify on basis and now they don't, you said that you go back and do a basis on them, but we aren't going to have all of that documentation that we did before. And so how is that going to be an apples to apples, like what you're really wanting to do, because you aren't going to have that documentation to look at?
Well, the only documentation theoretically that doesn't exist is around behaviors. And that is one thing that we've already had to do with initials, with people coming off the waiting list, is that we accept those things by verbal report. And honestly, the MFEI is accepting behaviors at verbal report as well. And so to me, that's apples to apples, because it is verbal report to verbal report, although it's not the old basis to the new basis. But theoretically, that's the only thing that we could not ask for the documentation on it, because it won't exist, is behavior data. The PCSP, the BSP, and the medication list, diagnosis list, all of those things still exist. And we could potentially get those if we needed to, if there was a reason to believe that we needed more information, we could ask for those things. I don't plan on it unless we need to for some reason, but you could still get those items.
KDAS was very specific in one of their last communications that there would be no documentation requirements on basis.
Okay. Okay. Thank you.
Mhm.
One of the, I guess if you're, one of the upsides to that might be that it might increase the tier, but the tier doesn't matter really so much so I'm not sure how that'll all play out, but there could be some weird situations like that, but I think it would probably be in the provider's favor, the individual's favor, if that's what happened.
Yeah.
I would like to get some feedback, like Heather said, as we move through this process. I think Heather has stressed to our assessors that we need to be very trauma informed, how we deploy this assessment, how we need to slow things down. This is a marathon, not a sprint. I worked very hard to get us the 3 months of transition time, and I want to make sure that that we're bringing people along at the pace that they can tolerate. And it's a big assessment. It's 13 pages, I believe. And you're not just asking questions, and moving on. You're probably asking multiple questions for each question in there, because you have to get feedback from all involved, and you have to seek to understand. And so I don't want this process rushed. I want us to be tolerant of what people need, but I don't want people to be rushed through this process.
Exactly.
And I really, a break, I think everybody's probably going to need a break during this assessment.
Yeah, absolutely. All right, last call for questions.
And there was another comment, Heather. Thanks, Heather. We look forward to working with you guys through this transition.
Absolutely. Thank you, Joe and Imran. Absolutely. The same, ditto, back at you guys. I'm very excited about this. It's one of those things that's been a big project for a very long time. I'm excited to get it to the next step and reevaluate, see where we're at, and adjust course as we need to. So.
Well, we had 80 people at one point on,
Hey, nice.
and you still have 72. So, that's feedback.
Awesome. Awesome. Well, I'm glad you all could be here. Please, if you guys go back to your teams and you are discussing this, or a week, 2 weeks, heck, a month later, you guys have questions or something comes to mind that you're not sure about, please feel free to shoot me an email anytime, or I'm sure Sherry'd be open to that, but I'm probably around in the office a little more often than Sherry is these days. But just let us know. I really would love to hear you guys' thoughts, and you never know what you don't know. And somebody will bring something up sometimes. I'm sure you guys have experienced that, and it's very helpful. So please reach out if you have any thoughts or concerns about things, questions that come up. Okay.
There was a comment. You guys did a great explanation. Thank you.
Oh, thank you, Lee. I appreciate you guys as well.
And then another comment. Thanks for hosting this training. It makes the transition feel less daunting.
Oh, Thank you so much, Sandra. And I will also have made a note about getting information about when documentation is needed. So you guys have that information in writing, just as you had asked as well. So, all right. Well, that said, thank you guys. Have a great afternoon. Stay dry out there. Hopefully the rain is over, and we will see you all very soon. Thank you.
Thank you, Heather.
Thank you.
Thank you.